We've tried it; it doesn't work. No, I'm just kidding. We haven't tried that. But ultimately, I mean, that's kind of the balancing act that we're trying to work through right now. I would love to see us continue to grow. I don't see. I mean, you are going to hit a plateau at some point in time. I can't be psychic and tell you what that plateau is. Honestly, if we're looking at what I typically say as staffing ratios, a lot of times I'll say if you have 8 PTs, then you need half that many PTAs. I mean, you need half that many OT staff, and then you need about half that many speech staff. So if we're looking at that, then we should really have about 4 OT staff. So I'm really expecting that we should see some growth in OT. Speech, we're probably pretty close to that, but depending on how much peds they do, you can see that climb a lot. I mean, there's a lot of work to be done in pediatrics. So we're close, but I still think we have room for growth.
Especially in occupational.
Especially in occupational therapy. Which takes a little bit of time because you say physical therapy and a lot of people know what you're talking about. You say occupational therapy and a lot of people don't. So a lot of it's education. But we are trying to do that. So speaking of education marketing, on the pediatric side of things, absolutely PT and OT, they're going down to Yakima, the Children's Village. Wait a minute, did I say that right? It's Children's Village in Yakima? Okay. So we're going down to Children's Village. Speech paths are visiting with the local providers for the birth to 3-year-olds to let them know what services we provide, to see if we can't kind of kickstart a little bit more on the pediatric side of things. I know that when we came on board and we lost Shelley to home health, a lot of the pediatric patients went down to Children's Village. They're so busy down there they can't see the patients that they have on caseload. And so we're letting them know, hey, we've got the services here, we can definitely bring them back home. And that's a no-brainer, really. The OT marketing materials that we've been working with have really gone over well. We've sent those out to a lot of the system providers. We're definitely seeing a rise in our OT caseloads. So I mean, there's still work to be done, but we're working in that direction, and things are going really well there. Just as a follow-up, last time I was here 4 months ago, we talked about meeting with the providers one-on-one. Just to let you know that has happened, and it is probably our #1, success as far as marketing. I mean, they've really responded well to those one-on-one visits. It was funny. I was talking to Marcus, and he said, "I wish I could have timed when I knew she walked out of the building, because it's like she walked out and the fax machine just started spitting out orders." So it was good stuff. So those one-on-one meetings are very helpful. And that's all I got. Ultimately, we're super excited about what's going on. I know that we're working really closely with Rhonda and Julie as far as looking at the annex across the grass from us. That would be tremendous to what we're trying to do, not only on a patient care side, so the patients aren't running, distances to get to us, but we can see them in one location or the other, and just have one campus where we're all included. But just the added space as we continue to grow and develop these programs, we're really excited about the potential that exists across the grass. So,
any additional questions?
When you say across the grass, like the parking lots, mirror buildings? Oh, okay.
Yeah.
I know there's grass in there.
So
sorry.
In October, they've been doing walkthroughs and working with the architect, and we're hoping to bring a firm number to prepare that as a clinic for speech and OT in October. We still have some tweaking to do on that, but it should come in well under the small works limit, so we should be able to do that big process and things like that.
Any additional questions for others?
How is Cerner working?
They're getting used to it. They're getting used to it. They're really getting to where they can document. Our goal is that they document while they're seeing their patient. That's the most efficient way to do things, and it actually helps to make the medical record correct. They've done some studies, and it's pretty tremendous what the difference is between documenting while you're seeing your patient. It's coming along. A lot of them are able to get at least part of their note done while they're seeing the patient. It's not a bad program. So
But they can access primary care or whoever the referring physician is, record.
Absolutely.
From
Yep. Yep. It is really nice to have a system that you can, grab resources from wherever they came from. Absolutely.
Any other questions?
Thank you.
Thank you very much.
Thank you very much.
Thank you.
Hope I didn't make you late.
No, I'm got plenty of time. I could answer questions for another 20 minutes.
There you go. Go ahead.
Thank you very much.
Thank you.
Thank you.
Okay, next up, we have Andy Olson with the Safe Catch Awards.
Yes, our favorite things. So we have our second quarter 2018 Safe Catch Award winners here with us tonight. And so a safe catch involves something that prevented an event from reaching a patient or staff member, prevented pain, delays in care, unnecessary costs, or workflow efficiencies. It was high risk or had potential for greater patient harm, such as communication errors, surgical site infections, or falls, or it led to improvement throughout the organization. So we have two people who will get awards tonight, a non-clinical and a clinical award winner. They get to be recognized here. They also get a $100 gift card, a letter from you all, and a banner put up in their department. So we'll do our non-clinical award. So Laura Cresto is here from KVH Family Medicine Clealum. She's a patient services rep, and she was nominated by Brenda Manier, the clinic manager. Laura discovered information missing in Cerner that was previously available in NextGen. This information is needed in order to offer and bill for certain client services at FMCE. In this case, the client missing from the choices was Hospital District 2. Laura was given the number for the AMS line, and she was able to get Hospital District 2 added. She then came up with a really excellent idea to match the current Cerner client list with the ones that were available in NextGen. By getting these added to Cerner will prevent issues in the future for our patients needing services. So extremely proactive and a fantastic idea on her part. So, thank you. Really forward thinking, we appreciate it. And so for our clinical award, we have Rose Vick, home health aide with Home Health and Hospice, and she was nominated by Cindy Knight, an RN with Home Health and Hospice, who's also here today. So Rose went to see a home health patient for the first time. Upon arrival, she noticed the patient did not look right to her, something her family members did not pick up on. The patient was short of breath, her O2 sat was low, and her heart rate was extremely elevated. Rose immediately reported this to the patient's case manager and called 911. She waited until EMS arrived to give her report of patient's condition, and she was transported to KVH due to the seriousness of her condition. Rose was quick to recognize the problem with this patient, take action to prevent further complications, and get her the care she urgently needed. Way to go, Rose. So, one of my favorite things, thank you so much for all you all do.
Yeah, congratulations. Thanks again. Okay.
I think there's people wanting to take pictures of you all.
Thanks for coming.
Thank you.
Before we get to our next presentation, let's just take a moment in case there's anyone who wants to make a public comment or announcements. Every time we have a meeting around 5:30, this is a chance for members of the public who might be joining us who want to make a public statement or make an announcement. If you do have such an announcement, please state your name and your address and try to keep your comments to about 3 minutes. Is there anybody here who would like to make a public statement? Okay, seeing none, then we'll move on to the next presentation. David Swarty, talk about Central Sterile.
So can I jump in here for a second?
Yes.
Was lucky enough to do a gambit down in surgery with Amy and her crews, and had an opportunity to go back to Central Sterile, and was absolutely so impressed with the level of professionalism and skill and the way David runs that shop. It was just amazing. Now their thing is infection control. So I would love for you all to have the tour I had, but I think we probably keep David Wayneck if we were traipsing around the sterile tour. So I think they've done a video to show you instead that it's amazing work they've done, and the standards that they hold themselves to are pretty amazing.
Congratulations. You ready?
Ready. Sorry, I'll be quiet.
Oh, it's okay. I just didn't want to think it.
Your integrity has to be above reproach. You have to make the right decision every time, all the time. People around you, people not around you, you can't cut corners. So the integrity piece is huge.
We can't provide standard care, surgical care, anywhere in the country without sterile equipment. Right? The infection risk would be prohibitively high without sterile equipment. It wouldn't happen. It would be illegal.
A provider wants to use a certain item, and they bring it to you to be processed. Maybe that item can't be processed there's numerous reasons why. I have to be able to say, I'm sorry, but we can't use this because we can't process it. To stand your ground, you have to have the information to back you up. So you never just say no until you have the answer ahead of time.
This is a small crew that works very closely together, and they're meticulous. The work they do is very, very important, and they like the work that they do.
You never rush anything in the name of time. You do everything step by step by step, and if step A takes 20 minutes, then it takes 20 minutes. We don't cut a corner to make it faster. Instrumentation is so complex nowadays that you actually have to have technology to keep up with the technology. So not only do you have to understand how this technology works, you have to understand why you need this other piece of technology to clean this technology. So it's not just put it in some water, scrub it, wrap it, put it in a sterilizer anymore. It's a highly technical field, and to stay in this field, you have to grow with it. So there's a whole education piece. You have to be willing to learn. You have to be willing to question things that don't seem right, and not be afraid to be questioned when somebody asks you, is this being done the right way? Just a regular set of bandages. There's nothing special. Everybody has them in every set. There are 37 individual steps to process this, and you have to follow all 37 steps, because if you don't, and something happens, a patient gets an infection, and through the course of the investigation, they want to see that you're doing it properly, and you miss step 5, and I mean, that's bad. You have to do the exact right way.
So not only are they important to surgical services, but they actually service multiple clinics and departments in the hospital. So they support every single department in their sterile instrumentation, every single clinic, and our clinics that are off campus as well.
So ORs are our largest customer, and they're high demand because their cases are turning over, and they can use hundreds and hundreds of instruments on a case. So you get into the total joints and stuff like that, you're talking, that would be probably 500 or more instruments just for a case. The OR, EMCS, it's a fluid situation, nothing static. You can't come to work and say, I'm doing 5 things every day. It's not going to happen. And if you think it's going to be the same as it was yesterday, that's not going to happen either.
They do a really good job of connecting the work that they do with the actual care of the patient. And sometimes that's a tough jump when you're in a space that you don't come face to face with that patient.
Everything that we handle, it goes straight to the patient. And if we don't do our work correctly, then that patient, we're causing them harm. We're in the trenches every day, and these guys are fighting microorganisms they can't even see, that are hiding in places that most people don't even imagine could get into. And they're doing it every single day, all day. And as soon as they get that battle won, these microorganisms find somewhere else to hide. So then you just got to go and do it again.
If a patient were to have a contaminated instrument, it could cause a delay in surgery, it could cause a surgical site infection, and that can impact a patient's life for months or years. I was a OR nurse for the first 27 years of my career, and I worked closely with several of the people that still work in sterile supply, and I have every confidence in them that they're doing a fabulous job.
The operating room environment is very complicated with a lot of people, a lot of things going on, and a lot of things to worry about and things that we take for granted. And taking our equipment for granted allows me to focus on the patient and perform a good operation and not have to inspect the equipment and worry about whether this equipment is up to snuff.
This is a crew that works behind closed doors. Most people don't know what they do. Most people have never heard of the job that they do. And it's so incredibly important. So I appreciate just the opportunity to bring their job to light and the awesome work that they do.
So that's why it all goes back to the technique. Time management, attention to detail, very technical, minded and stuff like that.
I know Dave is really nitpicky, but that's a great characteristic to have in his position.
So it takes somebody who's also patient, and it helps if you're able to see.
That was fascinating.
You didn't come clomp around in your sterile unit.
So are there, thank you very much. Are there any questions?
Yeah, I have a couple. For David, curious about so you're a surgical technician, correct?
I'm a certified sterile reprocessor, and I was a surgical tech.
Okay.
For like 28 years.
So what sort of training, education, background?
That's a long story. So I actually went into the military, went to the Air Force when I was 18, right out of high school, and I became a surgical technologist in the Air Force. And in the Air Force, you do both sterile processing and surgery. And so I did that predominantly my whole career. I retired from the military in 2011, and in that time period, I was a scrub tech in CS. I was also an orthopedic specialty tech, so did a lot of orthopedics. And so that's kind of how I got my training. And then, of course, our training is the same as on the outside for technologists. You have to go to school, get your degree and all that. So we did all that. And then I got out, and I decided that, doing 16-hour back cases wasn't for me anymore. So I just focused directly on sterile processing after that. So that's what we did.
So Dave does have certification in sterile processing, and so does his team. He's an amazing mentor and a leader in his department, and really without him, I would struggle real bad. He's really wonderful.
Now, is he actually in the operating room during operations, or it's all done in a lab?
We have our own department that is, at this facility, it's adjacent to the OR.
Okay.
Other facilities, it's maybe in the basement, larger facilities, whatever.
Right.
So here, we work right next to it.
Yeah.
So, but I do scrubbing as well. It's an emergency.
He does help us out.
I keep my license to scrub at the same time.
So a really important thing to point out about this crew, and I think it can be difficult for people across the organization, sometimes it's really hard to connect the work that you do with a patient when you don't see that patient. This team is really adept at understanding how the work that they do affects that patient directly. The things they process touch patients sometimes on the inside. So they're pretty good at making that connection, and it's a tough connection to make when you're in a separate room from everybody else and you don't see anybody else. They're pretty good at it.
And I'll just add that all of the staff back there are, what she said, in the certifications. That's required now. It wasn't before. It is required now. And they're all homegrown, so they're all from here, and they've all been brought in and have been trained from the ground up in that department.
So to maintain that certification, do you have courses you have to take during the year, or a certain time period?
So, as a surgery tech, in 5 years you have to have 60 credits, continuing education credits. In sterile processing, you have to have 12 in 1 year. So, and it's done that way on purpose, and that's so the technologies in the medical field change extremely fast. So, I'm not going to date myself, but I can remember when I did my first lab Coley. It was like, exactly right. We all thought it was voodoo, but we did it. But the technology changed from open to here we've putting something through a little hole, and now we have these new instruments that you have to figure it out. Now we're doing robot, it's not here, but assisted total joints, where the robot literally just holds the saw and makes the cuts. So the technologies and the Da Vinci's with all the arms, so the technology is moving fast. And so we have to stay up with that technology. And so our education piece is 12 credits every year. We're certified.
I really enjoyed the video to see what you're doing instead of just hearing it. I'm very visual, so I appreciate that. A nice tour, the video tour for that. Who put that together?
Jan Howard? Yeah. She's very helpful. She is. Twisted her arm.
Good crew in there. Very nice.
Yeah, this does.
Oh, go ahead.
Oh, it gives us a really good insight into, because in quality improvement, we talk about surgical site infections, and we look into rates of that, and it's really nice to sort of get an appreciation about how many people actually be doing good work for this to be effective.
Well, we make sure that the staff understands that they're a piece of that whole process. So when we have SSI meetings or infection control meetings, that we have representation, so that there might be something that we can add to that piece. And making everybody understand where they fit in the overall spectrum is extremely important for the career field. It used to be the career field of dishwashers. It's where you sent people who weren't up to snuff, and they just kind of went there and they scrubbed some pots and they threw it in the water. It's not like that anymore. A lot of states' laws are being passed making it mandatory for certification. Washington State's not there yet, but a lot of eastern states are there already. And so the education piece and the certification piece is huge, and it's being pushed more and more. So the technicians that we have, one of the things that we do is we just ingrain that we're always learning, and we have to constantly stay up to stuff. So we make education just part of the culture back there, so that everybody understands that we have to grow. Because if you don't grow, it passes you by.
Great.
And how big a staff is there? Maybe in the video I missed it, but
3 full-time, counting myself, and then 1 for me.
I was impressed by the parallel you talked about, and that's an important point about connecting to the patient, even though you're sequestered from them. And I think that I can appreciate that because my experience with the organization exists a great deal in this room, and I don't have that contact and that touchstone with other parts. So this is really great to meet you and see you make that connection.
Other questions or comments? Julie, did you want to?
I just wanted to toot Dave's horn once again, because part of what he's been doing the last few years is trying to get the numbers lower for flash sterilization, which is immediate use sterilization. And in the past, that has been used like if we didn't have enough trays, then we just flash a tray and reuse it. Flash sterilization does have a slightly higher risk of infection, so we try to make it as minimal as possible, only to use it as an emergency. If you drop something and it's the only instrument that can be used at that time, that is the appropriate time to flash sterilize. And I just wanted to give you the numbers of flash sterilization in the last few years. In 2015, for the whole year, we had 68 flash sterilizing. 2016, 75. 2017, 46, and 2018 we've had 4. So this is a really big deal. Infection prevention. Thank you, Dave.
Yeah. That's amazing.
Any additional questions, comments? Thank you for the work you do.
Thank you.
Appreciate it. Okay. everyone does to the drudgery of court today. I mean, come on, say that's your words. You know, come on. All right. Well, I guess we're gonna have to.
We'll have to do that anyway. The board soon.
Okay. All right, Mandy, you're up.
Let the drudgery begin. My report is in here. If you have, I do want to point out too. I have in my report about the Department of Health Plan of Correction, and on the last two surveys, though, the environment of care, they go back in Central Sterile and they observe them doing everything, and they always have the highest praise too for our Central Sterile. So they really do an incredible job. I don't really have.
I want to ask a comment.
Sure.
What's behind the name Central Sterile?
Julie and Dr. Bryan might know better, but I think the Central Sterile. Why that? I think it came from being behind the OR and like in the core of a building.
I think it is. It's like Central. It used to be like Central Supply and Sterile Processing, and so I don't know.
Okay, that makes sense.
Because I've heard it called at other institutions like the Central Core or Core, and I think it has to do with kind of where it is in the building and the adjacency to ORs. Questions about my report or the dashboard? There's some patient comments in there I've added again.
And I just mentioned on the DOH survey, one of the things that they brought up was that we did not have 96 hours worth of fuel in our tanks. We also discovered some other issues. That was actually constructed and purchased under the 1985 regulations. So we are 99% sure now that we're not going to have to go back and add a second tank. That being said, we think there's some value in that, so you'll see that coming forward as one of the regularly prioritized capital projects in the future. So we will go through an analysis of how valuable we think that is, but it won't be as a result of the DOH survey.
I have a question about the patient satisfaction dashboard on the clinics. It was kind of hard to understand what the dots meant, what the results meant. Can you briefly?
Which dots? Can you?
Page 20.
So are you saying that there's only dots and not any other data, or can you?
Well.
Or which is which? Is
well, no. What do those dots mean?
That we only have one data point for the clinics because they had a different survey method before. So the blue dot is the percentile rank comparatively for patients gave us a 9 or 10. So we're at like the 20th percentile for family medicine Cleellum compared to other clinics. You know, in a ranking, we're about 20th.
And so those are just 9s or 10s?
Who, yeah, got 9 or 10s.
And
for
so
overall, the red is top box score, 9 or 10s for the willingness to recommend the organization.
And so that's just all, that's data for only the second quarter of 2018. And we'll have more data in the future?
Yes. So we've had data previously because it was through Survey Vitals, but it's really not comparable to the Health Stream survey or the Preskini survey going forward. So that's why it's not on there.
Are we going to start seeing pediatrics in here, or is that not in this?
I thought we talked about that, but they're not coming out of Cerner.
Right. That we don't have ability to populate a data file to send at this point.
Okay. I noticed the sepsis measures are sort of up and down. And I know we can't talk about trend yet, but we seem to be doing so well for a long time there, and then it seems to go up and down. Any ideas as to if that's all?
It's not, so the number of incidents, they've been kind of all over the board. We've seen them where it's a failure to get the antibiotics started in a timely way. There's been blood cultures that weren't done prior to antibiotics given. There's been a missing second lactate. So they have formed a team. They've already met and done kind of a mini root cause analysis on it, and have implemented some strategies already to try and get that back up. So.
Okay, so there's a team working on it to identify.
Yep. Mm-hmm.
On page 14 where it says 2 hospital-acquired infections. So, so there's it's hard to time out where the infection came from and then how far forward that infection could go. What criteria do you use for that? The minor stuff, the major stuff?
What the criteria?
Yeah.
There's, Julie can talk about more, but CDC gives us the guidelines for what we can use to time an infection or not. And depending on the type of surgery is how far out you look. Like, and if I say anything wrong, please type up.
Anything with an implant is like 90-day surveillance.
Okay.
Any other surgery is 30 days.
Okay.
Superficial is 30. And their definitions are...
Very specific.
Yes, very specific.
So for instance, one of these on here is one that we wouldn't really like to count, and it doesn't feel very fair, but it's the standard that CDC puts forward and NHS then follows. If someone came in, with their colon ruptured, then, that's ripe for infection.
Yeah.
So but that still meets the technical requirements for a surgical site infection. So
even though I called them and
I was going to say, believe
on
it.
it. Are you sure this
Yes.
meets?
Really?
I know, yeah.
They got home
Believe it. Honestly, we've reviewed this every way we can, and there are only 5 surgery types that are actually reported to NHS, and then a colon is one of them. So yeah, we have to report that one, yeah. And honestly, in many of the state meetings we've been at, and some of the pushback has been that we follow the rules better than other people, and other organizations might not report that, but we do.
Fall under the same rules.
No, it's not it's not the colon. If you have a colon resection, that's the surgery that counts. That's what counts. So.
But like hospital acquired is kind of a misnomer in this case, because the infection is acquired before the patient comes to the hospital. So it's not begun here. It's just generated.
I guess we're all preaching.
But yet they term it acquired, hospital acquired, which is unfair.
And I know with this particular case it was superficial, so it was more of a skin infection, more of a lesser layer than like deep. It wasn't as deep. It was an incisional infection.
When someone comes in to be treated for, say, an infected wound, would that be something we would have to count?
No. These are particular for surgical, post-surgical infection.
Yeah, I guess as a mistake, it's like one infection leads to another, in a complicated case. So in that case that I was just referring to, actually it wasn't counted because of the infection already present. It was counted because the infection had moved to a different place, showed up in a different place, or showed up in the wound afterwards. Anyway, it's all it was with it.
Julie, I didn't bring my notes for July. They were do you remember?
I think it was an appy.
In the knee? Or,
honestly, I don't.
Well, I thought one.
Sorry.
I can't remember either. I'm sorry.
But an appy is kind of the same idea where you have an open valve, and it's not too surprising that there is an infection because you've opened.
And those, though, we don't have to report, right?
We don't have to report those, but I keep track of those anyway.
Just to keep an eye on.
Thank you. Yeah, go ahead.
Yeah, you might have already spoken about this, but the pain med reassessment, I couldn't see anything why that was discontinued.
It had to do with the reporting, and we're
back on it.
It'll show up on the next dashboard.
Okay.
We have a report from Cerner. We had to validate that the data was accurate before we were going to put it on here. So you should see that next month.
Any other questions or comments about the QI reports or the dashboard?
There's referral data on here I wanted to point out on this page 2 that is new. And one of the things we want to just, it's new. Carrie might have more to say about it than I can, but it's kind of hard, like the days to referral completion, the second one, where you have workplace health lumped together with like general surgery, or so it's that scale is so different between some of them. It's kind of hard to see. So we still may work on formatting in the future so that you can see a little better.
We felt like the spike there with February, March, and April was, well, there's no February data, but March and April being high, and then it's scaling back down. It's all part of that Cerner implementation. We felt it at that time. We're working out our workflows and figuring out how to get those processed. But you can see that we're back down to our goal of the referrals to a couple of days.
And those are referrals from any source, or?
This is our outward going referrals. So if you're seeing your PCP at Family Medicine Ellensburg and need to get referred to physical therapy, for example, how long that's taking.
So if one end of it is not within the organization, does it not end up in here? So like the origination of the referral versus where they're being referred to. I guess if somebody, independent organization, provider, whatnot, refers to us, is that being tracked? Like how long between the time we get the referral from them by when we
see them? That's not this data.
That's not this data. Okay.
No. But if you refer, if primary care refers to Orthopedics Northwest, that's in here. And we are looking at that discreetly to see what we're capturing within our system and what's going out.
Yes, talked with orthopedic providers about that last night. Yeah.
Any other questions about the dashboard or the reports? Okay, thank you.
Yeah, I appreciated your
You have good news.
Oh, did you want to talk about that?
Yes.
Oh, yeah. So I think I've mentioned in several, and Dr. Martin's not here, so I get to talk to Dr. Martin, but about the Greater Columbia Accountable Communities of Health, that we've been going to these meetings and working on these projects. And there's been some funds allocated to the Kittitas County Health Network, but KVH has also put in a current state assessment. We've set up quite a few things to continue to be part of the conversation, because there are things that are very specific to KVH as well, not just the community. So we had a meeting on Monday with some practice navigation, the practice navigators, and this is really the piece of the ACH that's focusing on practice transformation, so improving the care in the clinics and how that happens between the different care settings, so including the hospital. So they selected 23 priority organizations, which I think we've shared with you before, but none of us really understood what that meant to be a priority organization, what's happening. We had our kickoff meeting with them on Monday, and they let us know that how that will work is they are providing staff to us to help implement things in the 4 priority areas, the 4 areas of which are opioid crisis, the integrated behavioral health, transitional care, so between hospital setting, the skilled nursing facilities and the clinics, and chronic disease management. So on top of that help that they will provide us, including assessments to see where we have needs, like with the patient-centered medical home implementation, other things like that. We will also get $140,000 for 2 clinics each and the hospital, as well as $10,000 per assessment that we do with them. And that is for infrastructure to start with, is kind of what I've heard. So that was a huge surprise. They've laid out different ways, different modeling of how we would get payments or on top of other milestones. We met with our data, our goals, but this was totally a surprise to me. So
a total of 440,000
that I've heard about so far. I get the impression that that's just to start with for infrastructure building, and then as we go along in the demonstration project further, I think there will be still funds for meeting goals, but this is just to help put the systems in place so that we can have a sustainable program.
That's great. Yeah.
Well,
Yeah,
and what's exciting is this is work Carrie was already doing. It's
Yes.
work that they're
It's part of the
working on with the
strategy.
ACOs.
Yep.
So this is really not us chasing dollars. This is dollars that are going to fund their strategy.
And amazingly, this government program that they have set up, part of the assessment is to see how they can align with things we're already doing and our goals and how they meet these projects, which is just a wow.
Novel idea.
Wow. Yeah. So
what's an example of an infrastructure building? Or what could it be?
So one of the examples they gave is that one of the other priority groups has implemented a new EHR, and there's like an 1,800-page manual that goes with it. And where they really felt like they needed help was distilling that down into tools that their staff could use right away. That's what they're doing. They have staff to help with that and funds to help pay for that to happen. That's what that organization wanted. I don't think we would spend money on that, but that's what they prioritized together. So
now is this separate? Sorry, is this the same thing as the opioid?
No,
this is
that's my good news.
Yeah.
We have separate columns of good
Okay.
news. So yeah, the $200,000 was the first grant, and if you'll recall, part of Lauren Denton's time that we approved was as a grant writer, and this was one of the first grants after the gala that she went after. And again, this is work that our CHCW partners were working on. It's called MAT, or Medically Assisted Treatment for Opioid Addiction, and it's something that Dr. Azar was very, very interested in. So we used, the KCHN was not ready to go as a funding mechanism for this, or as a receiving party. So KDH stepped up and actually applied for the grant because we think it's in line with the community health improvement work and work with CHCW. So we applied, we got it. Our intent is to contract with the KCHN to manage the work and bring the partners together and continue to fund the work that CHCW is doing.
So the opioid grant is associated with the KCHN, and the infrastructure grant is associated with the Greater Columbia ACH?
yes. KCHN is doing other work though with the ACH as well. So don't, yeah.
I told you
Don't even try. It's taken me a year and a half to figure out.
I do think, is KBH the only hospital on the 23? I know that.
I don't remember.
I believe that's the case.
I didn't look at the list that. I think it's on their website though. The ACH has a pretty decent website, the Greater Columbia ACH. It's and there's a lot of information there. If you're curious, they have some great resources too, or just information.
I would just say we've invested the time and the people in staying at these tables, and I think this is really sort of paying off.
Absolutely, thank you, Lauren, for coming. That's great.
But it's Kevin and Mandy that have to make all the long trips to the Tri-Cities.
Wait, yeah, it does feel like it's worth it now.
Definitely very good.
Congrats. Any other questions? All right, thank you. On to the CEO report.
So I wanted to start with an update on construction, and I pointed out in my CEO report that I do have an ask in here. I would like some authorization. But Radio Hill is all but complete, and home health and hospice are moved in, and they like it. They moved in, I think this week. Revenue Cycle will move the weekend of October 6th and 7th. It came in, the firm bid, the contract that we got was $1,225,000, but it came in a little bit higher than that. I think the total was $1,238,60, but it was well within the contingency. So we did not cover the contingency. So Radio Hill Annex is pretty much, are you ready to move? We will be. And the planning went well. I heard there were some issues with the phones, but those were worked out pretty quickly and pretty well, so they're settled in. On Back One, women's health, similarly, we are still on budget under anything. So the original construction bid was 417, 900. We're at 428, 747. That's under what was included in the contingency. That's the construction component. We did have some change orders that we had to process. Most of those had to do with privacy. We were building up against the windows, so we had some, what's called mullions, that had to go against the windows to make sure you couldn't hear between exam rooms. And then we also had some extra work to do in the data closet that will support the rest of the building as well. But again, we're under the contingency, the total with contingency, and the project total was there was about 535 with all the equipment, and it looks like we're going to come in very close to that as well. And we are still anticipating that Women's Health will relocate the first weekend of November. Yep. So close in October and open in the new building in the first week of November. Yep. What I would like to do, Radio Hill, the week before, and correct me if I veer off course, man. I really exercised Mandy on this. She had to cancel things several times. The week of the October board meeting, I would like to schedule a special board meeting at the MAP. We would like to run an open house up at Radio Hill for the entire day. So if you had an opportunity to swing by Radio Hill and take a tour sometime that Monday, but then either that afternoon, that evening rather, 6 to 8 kind of range, have the board, some of the physicians, the architects, the design team meet at the MAP so that you can orient yourself to the first and second floor space. We still won't be able to get into the third floor, but you'll be able to see the women's health clinic almost at completion. It won't quite be done at that point, but you can see the finishes and how that's laid out. But really, by that time, I think the design team has been charged with knowing what services they want on the first floor, second floor, and third floor, how that's going to be divided out. And we'd like to have an opportunity to have the board, some of the physicians and the architect all walk through that and kind of see what the latest thinking is at that point.
Yeah, I think that's good.
Is that October 25th?
Is the week of the board meeting set in stone? Is there any chance it could be the week before?
She's going to throw something at me if I change it one more time. There's nothing magical about it.
In all fairness, the board wasn't consulted about our legal
Are there days that week that are better?
Well, I'm leaving to go out of the country on October 23rd, so I'm going to miss the board meeting and the finance committee meeting. But I really would hate to miss this.
What day are we talking about again?
So none of these are chiseled in stone. None of them have been advertised. So we were talking about the 22nd. And again, hoping you'd be able to see Radio Hill sometime during the day, but we can move that back.
What if I help you back?
Well, no, it's sorry. What about the 19th?
Is that Friday?
Mm-hmm.
Okay.
What time are we thinking about?
But you're not going out of the
It
country.
needs to be in the evening if you want to see women's health, because they'll still be working.
Maybe 6-ish.
6 to 8. It's your meeting, and again, if you need to choose.
How about you, Roy?
I don't have a calendar. I didn't realize.
No, that's right. Like a Monday evening, late October, probably, maybe. Nothing to bring it about. All right. Well, let's think on it.
What time are you talking about on the 22nd?
Evening.
6 to 8. But Mandy can do a poll. And
Okay. I might be able to do that.
We will probably leave the Radio Hill open house on the 22nd since that's a little more time.
So that's the 6th to 8th on October 22nd.
On October 22nd, the open house at Radio Hill is all day.
Oh.
So you can fly? Yeah.
So then the walk through the back would be 6 to 8. If we could possibly do it the night before, I really appreciate it. But if we can't.
Well, I think Bob and I are going to ask you to do something.
I will try not to grimace.
Okay, so let's just tentatively see how the 22nd sounds. 6 to 8 sounds like you may be able to swing it. Boy, if you wouldn't mind checking the calendar later. So anyway, so yeah, we can do that.
So
at least it's
2 activities or events that we're looking at, plus the October 25th board meeting.
Yeah, we're going to talk about having a special meeting to discuss the CEO evaluation.
Yeah, okay. Gotcha.
Although, I mean, I don't know, Bob and I can talk about this, but I think the plan was to try to get it in before the October board meeting, but I'm not sure it would be, we'd have to talk about whether it would be crucial to get it in before that meeting, or if this pushes back. What do you think?
Yeah, it might push us back.
Might push us back, but I'm not sure that there's any real time crunch on something like that. We can push something like that. Anyway, all right. Sounds good. We'll tentatively plan for October 22nd.
And then
you'll keep it open.
Tentatively keep it open.
The ask is, so the design and decision-making teams are moving ahead. We are through pre-design on the 3rd floor project. So that's where you get the bubble diagrams, and we need to begin moving forward with architectural and engineering, which is where the dollars really begin to flow. We have selected KDA Architect, they used to be KDF Architects, and they have proposed for, well, right now we are further along on the 3rd floor project than we are on the 1st and 2nd floor project. So our focus in pre-design has been on the 3rd floor, the big space up there, figuring out what we were going to do there before we knew what would go in the 2nd and 1st floors. So we're further along there. We do not want to delay that project. So this comes in the form of 2 asks. The first is to authorize me to enter into a contract for architectural and engineering and construction management. So this would get you bid documents, you'd have the blueprints, and then you would have KDA on to manage the build-out of the entire term of the construction. And
that's for which part?
The 3rd floor and the administrative pieces on the 1st floor and 2nd floor. So those that will not require pre-design for the clinic spaces on the 1st and 2nd floor. Again, they're a few months behind, and we don't want to delay the big project. So the ask on the 3rd floor, or what I'm asking for, is authorization to enter into a contract for the larger of the projects not to exceed $350,000 for A&E and construction management.
Motion.
Right, so the ask is authorized or to contract this not to exceed 350. Is it 350,000? Okay, so Roy, are you okay? Roy, next question.
So
yeah, question from
on a per square foot basis compared to women's health, is it similar?
So the way there's a state set architectural fee that is based on the estimated construction cost, and that fee typically runs about 11%. I asked Ron to go back, and so I calculated it as a cost per square foot on the project. I asked Ron to go back and tell KDA we wanted it at $25 a square foot. We actually ended up right in the middle between those two, so it's probably about $28 a square foot or so for A&E. And I don't have like a scalability answer for you. My reason would sort of imply that it's more expensive per square foot for that, that you get some economies when the project gets larger. But it's more than $25 a square foot. I think it's 10.62% of the estimate cost that they've estimated for the construction project.
Okay. What was that last part?
10.62% of the construction component of the project.
So I'm trying to grasp what the different components are here. So the remodel cost of $250 per square foot, and then the architectural and engineering costs are based on that by percentage. So the KDA ask is for $525, and that's only for architectural and engineering, or that's construction?
So I'm dividing these into two different asks. The $350 for the project we're ready to move forward with now, and $150,000 for the balance of the first and second floor that we haven't begun pre-design.
Not the non-admin.
The non-admin,
Yeah.
correct.
And that's construction costs.
A&E, architectural and engineering. So in total, we're looking at about $500,000 for architectural and engineering commitment, and then that construction management component of the project for everything in the building. And that also includes designing the removal of the elevator. And again, that's kind of on the bubble, so that's specifically called out as $55,000.
So this is the A&E for the rest of, we won't be looking at another A&E.
That's correct.
Unless we suddenly decide we
That's correct, and I've asked that in every way I know how to ask an architect if this is a firm number. This gets you the bid documents, it gets you through bid opening, and you're good to go.
And then for each component of that unit or whatnot, then we'll have construction costs.
That's correct.
Okay, thank you.
We're anticipating a $3 million
3.1
for the third floor.
With, call it 1,000 square feet of admin space on each floor, first and second, 10,700 square feet on the third floor. That's $12,449 12,449 square feet. $250 per is 3.112. And again, this is only construction, it's not project cost. And then $55,000 on top of that to deal with the elevator. So the total then is 3.167.
I really would have sort of appreciated some paper documentation because it's so many figures floating around, hard to visualize exactly what we'd be approving.
At this point,
Well,
it's just
the
approving the 350.
Yeah,
Not to
the
exceed.
first one, yeah, is the 350,000 for the A&E.
What's the 335 figure then? I wrote down not to exceed 335.
Sure. Now it's 350.
So that's, other questions, happy to take. There is a motion here to approve from Roy that, not to exceed 350. Do we have a second? And then we can continue discussion. Is there a second?
So the 350 is, sorry, I don't see that here.
I
350
had them update the numbers.
Oh.
So you got the early bid numbers.
Okay.
And I had Ron, in between the time I left and I got the new numbers this afternoon.
Oh wait, I wrote 350. That's for architecture.
Correct.
Alright.
So that's where we are, the A&E on the third floor, and then the admin piece on the first and second, not to exceed 350. Motion from Roy. No second.
I'll second, but then I call up.
All right, second from Erica. Okay, any question or discussion?
So the 3 points.
Stuff on the third floor and then the admin piece of the first and second. Do I have the?
So the 3.6 that we're looking at, was that the figure for?
3.167.
Was that the construction costs and the?
That's what they're estimating at this point.
So
the construction costs will be.
That's a number that we can look at for completion. Hopefully, by the time we're complete, that's the hopeful number that we'll.
On the construction side, again, the project cost, it escalates that. I mean, that's everything once the general contractor is done is included in the project cost, not the construction.
Just trying to
Did you
wrap
want to
it.
ask about the cost, the project costs?
Well, I guess I'm just trying to wrap my brain around how much more we might be on the hook for in order to have a turnkey, so to speak, for the entire building.
We don't have that number yet. And we won't until we have it designed.
Right.
Which is what A&E is about.
Fair enough.
But they'll open up for bid, so it'll be hopefully several competitive bids.
And to that point, they want to do, I will have an ask around some demolition costs, because before they invite contractors in, Ron and BK Powell and Randy are talking right now about it would be preferable to go in and quickly demo the entire inside so that the contractor knows exactly what they're working with and there wouldn't be any surprises then. That would not include the demolition of the elevator. So, but taking all the walls out, getting it back to where the contractor can see exactly what they're working with. They're thinking about doing that right now. And that would be in advance of you approving the big bid that would come back. Right.
Can you remind me, is that the third floor, is it still occupied?
It is until January.
So, again, I'm sorry, I apologize. I'm still not exactly understanding what we're being asked to do. Because I'm reading this and it's all under Medical Arts Center 2, but in other words, it sounded like initially we were talking about the second floor, but now we're talking about the third floor.
Project
could we,
2.
yeah, could we just have sort of a list? You are being asked to authorize me to enter into negotiations for exactly what?
Architectural A&E for the third floor, entire third floor, and administrative space on the second floor and the first floor, not to exceed $350,000.
Yeah, so that is the that would be the bulk now. That's separate from the stuff. So right now it's just authorized to do that, not to exceed 350, A&E on the third floor, administrative piece on the first and second floor. Does that make it clear to everybody?
Yes.
Okay. So that's what we're being asked for today. It's been moved by Roy, seconded by Erica. Further discussion. If anybody has further discussion or questions? All right, hearing none, then all those in favor of that motion, please say aye. Aye. Any opposed? Okay. Unanimously passed. Thank you.
My second ask.
Yes, go ahead. Is this regarding the MAG as well?
Yes.
Okay.
So this is the balance of the project, and we have focused our attention. So this is what pre-design looks like. So it's Carrie sitting down with the docs, coming back to us, sending it back to the architect. The architects are at the table. They're talking about the flow of patients, the number of providers, the concepts of how they want it set up, and what the demands are in terms of number of exam rooms and things like that. We very deliberately focused on the third floor because that's where the bulk of the providers are going to be. So we didn't want to confuse that by including in pre-design the second and first floor. We wanted to get this right and then figure out what the other pieces were. So the clinical spaces on the first and second floor have not gone through pre-design yet. We will soon know enough to say, okay, we want our rapid access clinic on the first floor. What does that look like? We want women's health to be on the second floor. What does that look like? And we'll go through the pre-design process there. So it is going to be deliberately behind the large project. We don't want to hold up the large project, so I'm asking for a separate A&E approval to move forward. And the reason I'm asking for it tonight is so that we're not sort of stymied by board meetings. The cost per square foot is the same, the cost on percentage is the same. It's simply coming as a second component. And based on those same calculations, it's $150,000 not to exceed. And that includes some for pre-design work as well. So that would be my second ask.
So that's for the clinical spaces in 1 and 2.
1 and 2. Correct.
Right, so this is it's a second ask, and I'm not trying to interrupt you. The second ask then is for A&E for clinical spaces on 1 and 2, because we just did the entire 3rd floor, and then the admin pieces on 1 and 2. So this is a separate ask for the clinical spaces, the A&E for clinical spaces on 1 and 2.
And it's not admin. 'Cause that's
Right,
already
non-admin, because the admin's already taken care of, and this is not to exceed 150. Is that clear to everybody what's being asked?
Second.
Okay, we have a motion from Erica, second from Donna. Are there any questions or discussion about that piece? Okay, hearing none then, all those in favor, please say aye. Aye. Any opposed?
I apologize that didn't feel clearer, and I will work on not surprising you bad now.
No, it's okay. One quick question I have, and I think this will take a second. And I know you've given us a timeline before, which is sort of a basic, very general, half a minute. So, occupancy October 24th, early November for women's health. I guess we're just wondering, well, I'm wondering, like what is the final, like we'll be done with this, it's all set, it's all occupied, everything's a go. What date are we looking for?
July of 2019.
July of 2019.
But
That seems
Julie's
fast.
number.
Yeah, that seems.
Are you okay?
Are
you okay?
I mean, that's exciting.
That's what we're doing. So that's why we are trying to move this along so that on January 1 we can get in there and do the demolitions, but we have the plans and we can take the bid almost simultaneously with DSHS getting out of the 3rd floor.
Right.
So there is a chance, depending that those projects might be flipped. By that time, we may find we're ready to move with 1 and 2. But again, there was some logic fallout trying to.
That's the goal. Everything's humming in July 2019.
July of 2019, Carrie, write it down.
Yep, I've got it.
What's your excited for the map?
So we are looking at, actually Michelle's done quite a bit of work on this. We want to, it actually for such a big building, it's not very visible from Mountain View. So we're looking at placing some lit signage between the 2nd and 3rd floor on both, and I'm going to get this wrong, the east side of the building and the south side of the building. So either direction you're coming from. We will have a monument sign. Jackson is going to be the primary entrance. So we'll have those as you're driving up, to it. We'll have a monument sign as you come into the building. Some minor signage along the other street there, to help people get in and out. But that's as far as we've really gotten with what the exterior signage is going to look like. We know we need to, we'll have people do the U-turns on Mountain View if we don't, announce that building is here with some big signage light up on the building. So we're still working on it.
You use the liquor store. Big arrow.
Such a great list.
So you laugh, but I sent them to the city to find out what we could do on somebody else's building, and I got shut down. So, but I have
no arrow.
Yeah, I wanted one of those, like the circular arrow. But Michelle is working on that, and I think she's looking to come to the board with that in October.
I just spoke on the Jackson, of course, Pine is the north south. So is Pine's on the east side and Jackson's the cross track that connects Pearl, but it's still off of Jackson is where they're going to connect? Okay.
Right. And really, it's less confusing with family health care in Ellis, Oregon. It's more residential on the Pine side, so we didn't want to mess with that.
And we can, you'll be able to sort of walk us through all this October.
And that is why we want to have that meeting, so that everyone stays oriented and we can talk about what services go on which floor.
And also, I should say that I don't know what we're calling ourselves, but the digital design group, or we met the other day and started talking about how to decorate. We didn't get very far. Over on Tuesday? I guess Michelle, we're all,
the art group.
and me.
Healing Arts.
And
Yeah.
I'm on that group.
Yeah, I don't know why you weren't there.
Well, I wasn't told about it.
I yell at Michelle, I guess.
Michelle, are you here?
She's not here. You can yell into the recorded YouTube.
Anyway, we didn't get a whole lot. It was just very preliminary. Very, we didn't make any decisions. We were just sort of.
Is that for the statue of you?
Yeah.
Doing a flyer.
That's a given. I think she just wanted to have me personally do that. Okay. So yeah, sorry, go ahead, Julie.
The only other things I wanted to mention, I wanted to call out some things that are going on up in Hospital District Number 2. They're moving ahead. They're doing tours of fire houses, ambulance garages down in the Tri-Cities. So they have a couple of board members and some staff going down there. So we're moving on this new garage up in District 2. And the other was we continue to have issues with dispatch, and we have a jointly operated or a two-county fire district up there that we're having some issues with EMS and the fire districts wanting to use the King County dispatch service. So we're working very closely with KitCom to make sure that we're meeting the needs of Kittitas County residents as best we can. It does have some potential to make it to a public meeting or to generate some comments, however. So, and I think that's everything I can remember.
What is your update for the CFO search? It says you're going to tell us in 40 minutes.
Oh, okay. So, well, Libby's retiring, maybe. Yeah, we have.
Bad at retiring.
Yeah, they keep popping up. Jan has accepted our offer. I'm not sure she was in that file. I'm not sure he told us why. So he has accepted the offer, and we're looking for the start date for the company. So.
I don't know that you've heard any before, but you don't need to repeat it. And what's the
He's from Good Shepherd in Wisconsin. He's been with a deputy editor for quite a long time. Really strong background. I literally did just interview with his boss in DC, feeling guilty the whole time. So
yeah, how was?
But not that.
Did you have anything to report back on the rural health advocacy?
It was there. Of course, we didn't have the sort of hair on fire repeal and replace that we had last year. It was. They did, however, pass the opioid bill at a conference committee while we were there. And one big win that we had there was with what's called IMDs, and it's the opportunity to treat substance utilization disorder in your community in small 16-bed units. And the federal government has always been very wrapped around the axle in matching Medicaid funds in these IMDs, and they've allowed us to do that now. So the House had a version that was only opioids and cocaine, and the Senate didn't have anything in it. At the end of the day, they ended up saying that we can treat any substance utilization disorder in an IMD for 30 days, and this has been authorized for 5 years. And really what that does, we have these two behemoths in the state, Western and Eastern State Hospital, where an awful lot of these patients get sent, and they get taken out of their home communities, they get taken away from their support groups. So to the extent that we're now allowed to build these out, I think it will be helpful for patients. So that was a win.
Great.
But 340B is still being threatened. AJ's suing him. Murray gets it now.
Any other questions? Last questions for Julie? All right, thank you very much. Next up, medical staff, we have the Chief of Staff, Dr. O'Brien.
Yes, we have just 7 reappointments this time. We have the list of Larry Berger, of course, John Harrison, Frank Smith, General Surgeon, Tim Gano, nurse anesthetist, and two radiologists, Sheldon Jensen with Yakima Valley and Troy Bell with direct radiology, and then Rob Merkel and Oren O'Connell, both allied health professionals up in Clayella. And we are recommending that these reappointments all be approved as requested and will be approved as requested.
Okay, so the motion would be to approve the reappointments of these 7 practitioners.
Make a motion.
Okay, I have a motion from Bob. Second from Erica. Any further discussion or questions for Dr. Boyd? All right, hearing none, all those in favor of approving these 7 reappointments, please say aye. Aye. Unanimous, thank you. Thank you, Dr. O'Brien. I hope I didn't drag you away from anything more important.
Well, I was led away. I'm sorry about that.
Well,
it actually wasn't an emergency. So I couldn't figure it out.
Well, thanks for coming. Dr. Martin's not here tonight. Is there a proxy report, or is just, anybody who has to wants to say anything about his report? Yeah, go ahead.
He had one, I'll give my best Dr. Martin impression, but he had one added item here that he had said that just there's some donor support that's coming to him in innovative ways to offer long care facilities in the county, and so he just wanted to let you know that he has been, I think he mentioned here that had some wildly productive impromptu meetings with community members and leaders. So just he wanted to let you know more to come on that. So I know.
I've never had one.
So
particularly impromptu.
Any update on the jail contract?
No, not that I know of. Do you have an update on the jail?
Actually, I do.
Oh, good.
As a matter of fact, we are working with Dr. Russ Meyer with CHCW at the Yakima. There is some potential there if you can get resident engagement in third-year residents providing that service. It will look a little different from what was originally in the RFP potentially, but it will be something.
Wow, very good.
Creative one.
Yep.
Great. I guess, is there any discussion or anything about Dr. Martin's report? Okay. Thank you, Dr. Martin Standards. All right, next on the CFO report.
Yeah, I would really like to be able to start mine by saying good news. But that's not the case. That is not the case. You saw the results for the month of August. In my report, I talked about the issue around the deductions from revenue and our gross revenue continuing to be below budget. We have managed our expenses, I think, really, really well in most cases, although we do have higher than budgeted expenses for purchase service related to the Cerner implementation. We did budget expenses related to that, but I just don't think we budgeted enough. We're still working through issues on the billing side and the coding side. We had a lot of resources that we hired for coding. We took a look at what we paid for it and didn't feel like we really got what we paid for, and it was a significant amount. So we do have some work to continue to do there, but I think we're looking for some different resources there. We have some good news that we found out. I think I mentioned to you last month that we had difficulty having accounts that were to go to our third-party partner for self-pay collection, and some of our collection agencies, they were stuck in a queue, in a Cerner queue. We couldn't get the information out to that third party. That actually was resolved this week, so that they've now gone to the third party, which is excellent news. We'll be able to get those handled. So to try to address the shortfall, we will be talking with the department directors at the director meeting on Monday. We'll be, I think, implementing some approaches to reducing expenses, because in this scenario we really don't have much other than expense reduction. You know, we can continue to work on the claims, but I think that the reality is that we're we are being paid less than we were previously, and our payer mix has changed also.
Oh, yeah.
Less by our third parties. I think it's, pardon?
For what reason? Like for the same service they're paying less?
Yes, because that has been, from the payer perspective, they've ratcheted down on payments, period. Our error in this was that we budgeted back in October and November based on what we thought we were being paid at that time. It's been difficult in our old systems to drill and to understand what we were getting paid. When we were audited, we had an adjustment, but we thought that, I'm sorry, I should have said something different there. So we budgeted based on what we thought we were getting paid last year. But we also included an improvement in payment because, as you recall, we worked on the Kaiser contract for some time, and we had anticipated that we would have that payment change in January, and that I think we also assumed that there might be a little bit of retro there because they'd underpaid us for so long. Well, that didn't happen. And then our payer mix has changed. We have a bit more on the government side than we used to have. So I think the combination of all that, and when we actually did the research in the month of, for the month of August, it became clear that we're not going to make that up in reimbursement. We should see some improvement from Kaiser, but I don't think that we can assume that we're going to make up that shortfall in what we assumed for the budget.
I want you to be able to have the happy news. Is that something you're looking at and still think it's possible to, hey, this is a great report?
I'm sorry?
Is it possible moving forward that there will be a good report, a good report?
Well, I think
that you'd be happy about?
Well, we under budgeted contractual adjustments for the year.
So, and the issue with that is, to a large extent, contractuals are going to be what they're going to be. You behave with your expense budget very differently. So we're kind of caught flat-footed here. We knew we were going to have a rough year because of the Cerner implementation. But again, under budgeting contractual, gross charges are becoming irrelevant. It's that net number. Right. We overestimated what we would have in net. We are having a conversation now we would have had in October, November of last year about how we're going to manage these costs.
But we just didn't have the information last year. Right.
Well, and the other thing I'd like to note is that if you look at the bad debts and the financial assistance, they're over $300,000 for the year too. So those areas have increased as well. Financial assistance is not necessarily real surprising to me. I think there was a prediction in the industry that could happen as people, with the high deductible plans, as they were able to handle something once, but maybe not more than once. The provision for bad debts, some of that could be because of our working down our legacy accounts, that kind of thing. So,
are we feeling fairly confident with forecasting abilities for 2019?
We will be very confident in our forecasting abilities, but it's going to require a lot of discipline on our part as we develop the budgets, because I think we need to acknowledge that we're not going to be reimbursed the way we have been in the past. Now we are in the process, we're in the process of filing our interim cost report, and as you remember from previous years, we do that partway through the year. We send that to Medicare, and they determine whether or not they owe us additional funds for the year or not. That is very difficult to estimate throughout the year.
Is that part of the critical access?
Yes, it's part of cost-based reimbursement, and so they look at what our volumes were, what our costs have been, and determine whether or not they owe us more money. It's very difficult to predict that. Last year, we ended up actually not getting any more money. I think we owed them a small amount back because even though our Medicare, our days were down, our costs, we kept our costs down, so they didn't need to pay us anymore. This year, our costs have actually gone up quite a bit from last year. Our volumes were up slightly, so it's difficult to anticipate what that means. But we can't manage expenses we can't assume that we're going to get a lot of money from that, because then we don't put into place the changes that we need to make in case we don't get it.
So can you focus specifically on the accounts receivable days and what accounts for that?
The accounts receivable days?
Yeah.
Well,
that seems to be steady.
Well, they were down one day, but part of that had to do with the inability to get those bad debts off of the accounts. But we have, I think, as I mentioned early in my report, we had a number of consultants working on us on the coding side. And when they were working with us, we were able to bring our discharged, not final bill days down a bit, but not enough. We discharged those folks because they were charging an incredible amount of money, over $100,000 a month, and we didn't see the results that we felt like we should see from that.
So when you say coding, are you saying that this is still the results in part of the EHR?
Yes, we still have a logjam in coding that we're working through, and that it has to get through coding in order to get to billing. But it starts the count on the AR days when it hits the queue there.
In the coding, is that an issue of perhaps insufficient documentation that has to be chased down for each case, or is it?
There's a piece of that. What I am hearing is that with the new system, it's taking longer. There are pieces of it that are taking longer. And they have to look in different parts of the record for pieces of information. And so that is taking longer.
Who's the they?
The coders. The coders.
In health information.
Yes.
Are they part of our staff?
Yes, they are, although we have augmented it with some external ones. We've been down a coder on the clinic side, which has also slowed things down a bit. So,
and we still think that to change the server was a good idea, right?
Well, you heard earlier.
I mean, it seems like it's been kicking our butts for about 5 months, 6 months, something like that.
Well, you heard earlier from Rehab Visions that it's great to be able to see.
Okay.
I mean, and if we remember why we wanted to do this, it was to have one medical record.
Right.
So I will just say yes, it was the right thing to do, and I was the one that said AR is going to get above 100.
And we don't hope it.
Yeah, but it's time to start moving AR.
What's the value of those 83 days? What's the number tied to it?
Well, what's the total?
14 million up in AR.
Yeah.
But again, that's not driving the income statement problem. And we're blessed to have cash on hand.
Right.
Otherwise, we'd be out of cash. The income statement's being driven by the amount we're getting paid for the bills we are getting out the door.
Right. We also had, as you recall, last month, I think I reported that there was a holdup on Medicare paying. Part of what hit during the month of August was that we got a lot of payments that came through. And if you see on your average daily collections chart, that was up higher than it's, I think, been all year. But what hit the books was, with all of those coming through, there were a lot of contractuals that hit in that month as well. So.
I have a coding question.
Sure.
So when we say coding issues or challenges with them, is this like the ISP and diagnosis? I mean, is this like diagnosis and procedure codes, or what kind of codes are we talking about?
Well, they have to put CPT codes in, typically for billing purposes. What does that stand for? Do you remember? Procedures. Yeah. Right.
So this is,
and in some cases, diagnosis as well.
Perhaps I incorrectly assume that when somebody comes in for treatment or care, one way or another, that is tied to their appointment and how they're entered in. Is that something that doesn't just organically populate when they're seen? Everybody has to have.
No, not necessarily.
Yeah, they're reviewing all of those. Yeah, so it will populate, and the coders will see it, but they review and they audit to confirm that it's the correct.
Okay, so they're not starting at ground zero and getting like a patient chart and saying, okay, well, what happened here? Let's go trace codes or something.
I don't think that automatically drops on the hospital side. I think they have to code it from what's documented. And I think we are looking at whether or not, from my perspective, I think we're doing a lot more review, and the coders are doing a lot more entering of charges than they did under our previous systems. We have had some discussions about how much they've taken on as far as coding for the clinics that we think that was done previously by the physicians and not necessarily reviewed all the time and changed. That's something we need to talk about. But I wonder if there are things that we could have set up, done a little bit more setup in Cerner where we developed order sets that would drop diagnosis or charge codes, that kind of thing. So those are things we're looking at to fix.
I just assumed by the time the patient was out the door, that stuff had just populated.
Yeah. There's a lot of looking at the record in a lot of different places to get all the information. One of the ones that's been shared with me that's extremely difficult is infusions, because they have to go through the record, and there's this very complicated algorithm of when they started what. Infusions meaning they're in here getting multiple medications, right? But they have to go through and figure out what did they start when, and so which do they charge for how long, and it's very complicated. I think my sense from what I'm hearing is that there's a lot more on the billing side and coding side that's manual compared to what they had before.
But the trade-off is that we should be able to capture more from that manual coding?
Potentially, yes. But it would be nice if it were a more automated system.
It's interesting. We used to, as surgeons, we used to code all our own CPT codes.
And you're not anymore.
And we're not anymore.
Right.
And that's my understanding as well, and I believe that was a mistake. That needs to go back to the docs.
Yes.
Yeah. So we are actually looking at that.
Mm-hmm.
And I guess when I think about that process, it's fine to say we need to get paperwork like that off the doc's desk. But the doc would come out of the room or come out of the encounter with an idea of what that code should have been.
Mm-hmm.
They know how much time they spent. They would document to that, and they put in level 3 or level 4, whatever it was. Those coders are getting it without a code now. So they have to start from scratch, and they have and I believe that change was a mistake, and we do have a meeting scheduled to look at that.
I think we're meeting Monday to talk about it. And you think about it too, if it's happening, the physician, it's still pretty fresh in their mind what all occurred. And they were there, and it's fresh in their mind. Coding wasn't there. And it could be 2 weeks, 3 weeks, 4 weeks before they look at it. So there are things that we can do to fix it. So, yeah.
One issue that we discussed in the Finance Committee, and that is evident from the statistics and indicators and the revenue statement, is the continued underperformance of the clinics. For example, for this month, we experienced a loss of $328,000 over budget. We also, and we also had a shortfall against the budget of 491 visits. And the bottom line for me is, having been on the Finance Committee all these years and having been involved in the hospital, I still don't see significant improvement in clinic performance. In fact, I don't know, Carrie, if we're told this by the committee would like to have you attend the next Finance Committee meeting so we can drill down on some of these issues. We understand that part of the problem had been the going live of Cerner, but it is 6 months since Cerner has been in effect. And we understand the issues with the cultural changes. Most people who work in the clinics have worked there for their whole careers, or for many years, and there was an established culture in the clinics, and as we gradually acquired them, we're trying to get them to be more acclimated to the system way of doing things rather than the individual clinic way of doing things. But we still feel that clinics are underperforming, and least there's probably some very good explanation for some of that, but we'd like to hear it.
Sure. Yeah, and if I may, I'd like to point out to the board that our actual year-to-date, so our actual to our budget, we're right on track, if not a little bit above by 1.9%. So I think, yeah, there was that.
It's more of a, it's kind of a vicissitude by month sort of thing. Some months are good, some months aren't.
Yeah, so I think that's why I keep my eye on that year-to-date, because I agree. I think that we have that ebb and flow, and particularly in August, we had family medicine at Ellensburg alone. We had quite a few providers leave and just new providers coming in. So just that ramp up.
I understand that.
Thank you.
And I think that just the context of all that for the committee would be very useful. Because we just tend to look at the numbers and don't fully
I'd be happy to attend.
The visits anyway are up from last year quite significantly. And so is that because of greater efficiency, or is that more providers?
Well, of course I would like to say efficiencies and providers. Yes, both.
I mean, the bottom line is the more we provide access to primary care, the more we're going to struggle to make the bottom line. Primary care is not designed to make money.
Yeah, understand that.
So, but understanding what the right amount of loss is in the clinic, I think is where we need to get. But primary care is
problematic, and I think the fact that we opened up all the practices should show positive numbers as we go through the year. And that's a very good development. But there are some efficiencies that we talked about. One of our new finance committee members is somebody who has a lot of experience working with efficiencies in healthcare, and she has very good suggestions and identified some concerns. That's Deborah Rozzona.
I talked with Carrie about the suggestion that get together and chat with her.
Yeah, so we want to try to wrap our minds around it. But by the same token, I know that you've been very attentive to these issues. And whenever I've called you with an issue, you've gotten on it right away. So we really appreciate that. It's nobody's fault. It's just a long history that's accumulated over the years.
Bob, do you have any questions or comments?
No, thanks. Accounts receivable, the longer that goes out, the less likely we are to recoup those monies.
Yes.
So there's this urgency.
I'd like to say that you'd see a big improvement after September, September's numbers, but I think it's probably more likely that it'll be October's because we have to, it's the end of September right now.
Is that timely filing, is that based on the initial claim submission? If you get an initial claim to insurance within that window, do you have more time to amend the claim, or are you kicked after, I can't remember how, is it 6 months?
It depends on payer.
Okay.
Most of ours are at least 6 months, although we have a few that are 90 days, and we've been making sure that coding knows, and when they're looking at the accounts that we're getting those in.
So if we go, say, like a 90-day payer, if we submitted it, say, 30 days, we're sooner than that. But
I wish.
But let's say we're just rocking, getting those in right away. But there was an issue and they kick it back to us. And do we have? Is that still subject to that 90-day window for the?
I don't think so. I think
get that first claim.
Okay, that's good.
It's that first claim. So our legacy accounts, I think we're doing very well in collecting those. We brought back the ones that were in Next Gen. We're finishing those up in-house. We still have a fair amount with Paragon that they're working for us, but we're working it down and we're holding them accountable. We don't want to bring those back in-house. We need our people focused on the new system. So.
Any additional questions or comments? Did you want to say anything about the 2019 budget schedule, or you think it's good enough just to have the schedule here?
I just wanted you to be aware of it and be aware that we'll be bringing that high level to you at the next board meeting, because as you recall, we have to do that in order to file for our maintenance and operation levy, our regular levy.
Okay.
Okay. And then we do have a capital item.
Yep, Leanna?
Yeah, the Finance Committee reviewed the recommended purchase of the patient monitoring system upgrade, the Philips monitoring system. We noted that the actual cost was quite a bit lower than the budget that may even be lower than the
Yes, I think it's been negotiated down from this by about 11,000.
Who did the negotiate?
Morgan.
And Vicki's here, she can actually, we didn't, Vicki was not, nobody was at the finance committee who could really talk about the real function of this, so, but I know Vicki can speak to it if you have any questions
Right.
about it.
It's the cardiac monitoring system that we use in all of the departments. So it's critical care, med surge, the recovery room, surgery room, emergency room. We're kind of integrating so that we all use the same system. We've got various kinds of systems now that kind of talk to each other, but Philips is our provider, and so it touches a lot of patients every single day. Every surgical patient, every outpatient, the ER in particular, and critical care. And it was like 4 years overdue.
So the committee recommended unanimously to purchase.
Just do eye washes. I don't read everything.
Just strap an eye watch on each patient.
You can hold it too.
Okay, so we have capital expenditure request here, unanimously approved by the Finance Committee. I have a motion to accept this request.
So moved.
Motion from Leanna, second. Second from Roy. Any additional questions or discussion? To approve the expenditure request for a patient monitoring system.
Thank you. I have a question here. It says to update it housewide. Is this a replacement or?
In most of the departments, it's an internal upgrade of our currents, but there are some older machines in some of the areas that need replaced.
Okay, so those will be replaced so that they're all
correct.
Working together.
Right.
Additional questions or discussion before we vote? Hearing none, all those in favor of approving this capital expenditure request, please say aye. Aye. Unanimous, thank you. Leanna, anything else from the Finance Committee? Thank you. All right, operations reports. Vicki?
I guess that's me again. Just a mention on the monitoring equipment, we plan to have that installed beginning of 2019. So we'll purchase at the end of this year and then have it installed and trained, because the staff all have to be trained on that as well.
Well, thank you. We're sitting in the dark.
It's buzzing now.
Time to wake up.
So, any questions on my report?
I'm really excited about the way the food service department is evolving its approach. I think that's very exciting.
Jim's done a great job, fantastic job. He's kind of adjusting his staffing. Prior to that, people were working like 6 days a week, have one off, and have another 5. So he's adjusting the staffing. So I think the workers and staff in those departments are just as excited as we are to see things evolve.
The question about the staffing challenge mentioned for med surgeons and CNA, some of the staff there moved to the emergency department and births there. Is I'm imagining that's a progression for their career. They're advancing or following a path that they are hoping to follow. So, I mean, that makes me happy, even though it's no fun to deal with replacing.
Right.
I mean, that we have that opportunity for people to grow and advance. So, I appreciate that being pulled out.
Med-surg has typically been the growing unit. That's where new grads come. People learn their basic skills, get their time management and assessment skills. And once they feel confident in that, then they start looking into learning, and growing their skills.
And from my experience, that's really normal in hospitals for a medical surgical unit to be that way.
Do we have any long timers in med-surg, or is it just?
We had one long timer that just retired a year ago, and she was there almost 30 years.
Oh, okay. So there's a mix then.
There's a mix. There's some people that just love it, and that's where they get on to.
Additional questions, comments? Thank you. Rhonda Holton?
Yes. Well, I guess in addition to what's in my report, I would let you know that for home health and hospice, Kathy Murray has accepted the clinical manager position. She was a case manager for home health and hospice, so we're really excited that we had one of the staff nurses step up to be a manager. So we'll be working with her for some training, and this is her first, well, she's been a supervisor before, but this will be her first real management job. So we'll be giving her a lot of support for that. One thing that I didn't include in my report is that Swedish has notified us that for their specialty services clinic at Family Medicine Cleellum, they are looking at putting Dr. Gar there. He is a surgeon, a spine specialist with Pro-Alliance Surgery, and he should be starting sometime at the end of October or the 1st of November. So that didn't make it into my report. And also I wanted to point out the comment about CHCW. We're losing that potential revenue from the lab. And I think we estimated that that will be about $257,000 to our bottom line. And we did invite Stacy Olea. I don't know if you've met her before, but she's our director of diagnostic services, so she has lab and imaging. And she can share with you some of the things that we feel like we can implement with the frontline staff and down in the lab to help mitigate the loss of that revenue.
So one of the things we're really working on, and the clinics are taking a big role, is ABN, the Advanced Beneficiary Notice. So Medicare patients, if you have a test like a hemoglobin A1C, you can do those once a quarter. If you, let's say it gets ordered more frequently, if you don't sign an ABN, we can't bill the patient. So the ABN lets the Medicare patient decide, one, I want to pay for this test on my own, so bill me directly. Two, run it through Medicare first, and if they don't pay, I agree, I will pay for it. Or three, I don't want these laboratory tests, I'm refusing the tests. So historically we have not been collecting those, and that was a potential loss, I think in 2016, of about $135,000 for the lab. We couldn't bill. So the laboratory started collecting those in 2017, and now we're rolling it into the clinics with Cerner. Cerner also gives us a notification if an ABN was signed or not. So we know once that patient comes in the lab, if it hasn't been signed, we have an opportunity to have that discussion and then refer them back to their provider if they have additional questions. Advanced Beneficiary Notice. We are taking a hold on capital requests for the laboratory right now. There were a few things we had in the capital budget. We're just going to take a step back and look and see where we are. And for staffing, the last thing we want to do is layoffs. So we're looking at using our per diem staff more until we can really see what type of revenue loss we have.
What was community health's rationale? I know we've talked about this before, but I don't remember, for moving away from our services and hiring, contracting another lab.
They gave us three reasons. The first one is standardization. All of their clinics in Yakima and Sela are using LabCorp, so they wanted to standardize with the rest of their clinics. The second reason was pricing, because they do serve a community that does not have insurance or is underinsured. LabCorp's pricing is significantly lower than what we could offer. And then the third reason is we did struggle with implementing an interface with CHCW with the conversion of Cerner.
So even offering to put a body in their clinic, that was just a go for them.
Correct.
Any questions? Thank you.
Thank you.
All right, next up, Terry Barr, Chief Clinic Operations.
I have absolutely nothing to add except I will take questions about mobile kit.
Well, I think it's the news about the pediatric staff being pleased to be part of OAH is very good news.
They have been incredibly thankful and verbal about the fact that we've taken it slow in terms of everything feels the same to the staff as well as the patients. And so the only change they've noted has been the sign on the door. And that, they've been thankful for that. There will be changes. Any other questions?
I am thrilled, and I know it says a lot for Keys, for us to be actively working towards that. As a community hospital, I think that we need to, at least on a basic level, be serving pediatric population. This is good.
Any questions about the dashboard or about the report?
So I just want to step back a little bit on wound care clinic. Nikki, I mean, I think that's great. 15 a week, we're ahead of performa. 45 patients that we've probably seen, or 60 patients for the
Right,
month.
61, I think.
61.
Probably more since then.
I think that's significant for our community having that. Should have missed it earlier.
They're still working through their processes and learning and trying to find the right flow, but the patients are getting their care.
Thanks.
The high number, I think I'm reading this correctly. No, maybe not. Right. I got it now. I guess I was looking at the numbers of the third available appointment. So the high numbers there for, what is that, women's health?
Yes, we've got a pretty large demand for women's health still. We've been chatting with Dr. Ginger and Dr. Ginger Longo about that, about being proactive, what to do. So we have Dr. Thomas in Cleveland, FPOB, and he will be able to start helping out. She will stop traveling up to Cleveland, and he will take those Cleveland patients for those every other visits type of thing, and that's going to help with some of the access.
And the dermatology, I noticed, is...
yeah, so that's a new little dot.
Right, a new dot there. That's good. Is the idea that that demand is just starting to ramp up now because people are becoming aware of it?
Yes, so still pretty easy to get in to dermatology. We're booked out probably about 2 weeks. That's been steady. We haven't really booked out any further than that.
Because on the one hand, it's good to see that they can get a quick appointment. On the other hand, it's a sign maybe.
I hear you. I hear you. They're both a business, right? Yeah, so I understand. It is a delicate balance.
Can you remind me how many days a week you're for the dermatology?
2 days a week. 2 providers. For 2 providers. And we have Dr. Oldcamp who's looking to expand, and she would like to have 1 day in Cleveland and then 1 day in Winston. And that would be effective in November.
I forgot to ask Ron, the spine surgeon?
Spine surgeon, yeah, spine specialist. He is a neurosurgeon. He is the one who was coming to Swedish when they had the primary care clinic here, so a lot of patients will remember him.
And is that their first specialty placement there?
Yes.
All right.
Yes.
Thanks.
Happening.
Any additional questions for Carrie? All right, thank you.
Thank you.
So Michelle's not here. We got a copy of the community relations report.
Even though she's not here, I would like to take a moment to appreciate all the, this is a fantastic thing. I love being able to see what's on the horizon, what's coming up, what we've done. It's clear that we're out there in the community. It seems like I can't go anywhere without seeing KVH somewhere. So, and I'm still seeing kids in their red shirts, the KVH shirts. So that's cool. I saw one in Yap the other day. Oh, it's Noah's birthday. So it's pretty cool.
14th, month of the break. Are you doing that, Julie? This year?
Walk for the break. Walk slowly for the break. I haven't committed yet.
What is the
It's
deadline
it's
for committing to it?
yeah. Well, I think it's fast.
We've all sent in shirts, but.
I don't know.
I think you can register race day. You can show up and register, but this shirt piece is kind of gone.
Okay. Any other questions, discussion regarding the community relations reports? All right. Nothing under education and board reports. No business. All right. CEO evaluation process. I just want to say a few words about this. So Bob Davis and I are sort of heading up this process along with Carrie Youngblood, who's been assisting us in this. We put together two sort of evaluative instruments, right? So one is for the board, and the other one is for the senior leadership team. Because it's not part of the CEO's contract that her salary sort of depends on this, we're not doing a full kind of 360 evaluation. But we would like to get a pulse of the senior leadership team and the board. So we developed an instrument that we're going to provide to the senior leadership team shortly after, assuming that the board approves it. I'll email that out to everybody on the senior leadership team, and we'll probably ask for like a 2-week turnaround on that. If you can get us back comments in 2 weeks, and you can send it directly to me or to Bob Davis. And I think we have copies of it here. And then we also have copies of the board, the evaluation by the board for the CEO. So what we're going to do is the board then is going to complete our evaluation. Bob and I will review the materials and try to summarize kind of major themes. And then we'll get that report to the rest of the board. For the senior leadership team, Julie's not going to see the raw kind of evaluations that you guys give. It's just going to be a summary that Bob and I make of it. We do mention on here, and you'll see this shortly, that we're going to try to maintain anonymity. But of course, if you mention specific incidents or things, then that it may be a little difficult for us to maintain anonymity on that. So just please be aware of that issue. But Bob and I are going to be particularly mindful of that and try to just get kind of major themes. The other thing is that Carrie and Bob and I, or at least one of us anyway, are going to try to set up an in-person meeting with at least some members of the senior leadership team, where we can kind of get some feedback and have more of a conversation about your thoughts. We're going to try to do that, obviously, sometime sometime in October before the board meeting, and we'll work with Mandy to work out a time that's agreeable. Yeah, 22nd. But Liana doesn't have to be there, so that's fine. So we're gonna. So in addition to the written evaluations, which you guys can send, as I say, directly to me or Bob, then we're also going to have kind of a conversation with you, the board as well. Please, if you wouldn't mind, trying to get the written evaluations back to us in 2 weeks. And what will happen is, assuming that we approve this after the meeting, then I'll email electronic copies. With the senior leadership team, I'll probably ask Mandy to do that for you guys.
You'll email copies of the form?
Yeah, copies of the form, yeah. And then what's going to happen is the board is going to have a special meeting sometime. October seems to be getting a little packed, so we may try to find something, shortly after the October board meeting, where the 5 of us can get together, and then we'll go immediately into executive session to talk about the evaluations and CEO compensation. And so that's kind of the timeline, that's the process. Are there any questions from anybody, either on the senior leadership team or on the board, about the process before we review the specific instruments themselves? Any questions?
In-person interviews would be with the administrative team, but the board will discuss on a special executive session meeting.
Right, Bob and I and Carrie are going to sort of facilitate that, and then we'll get feedback and we'll incorporate that into our into our summaries. So the board will see the raw evaluation data, and we will see the summaries. So you'll get both. You won't just get the summary. Senior leadership team. I just want to let you know that she'll just see the summary. Julie will just see the summaries that Bob and I give, not the raw evaluation data. Okay. So before we review the instruments themselves, are there any questions just about the process? Julie, do you have any questions about the process? No, sir. Anybody else questions about the? Does that seem doable? 2 weeks? It's,
Yeah,
okay.
that's pretty normal with other employees.
Any questions about it before we look at the instruments themselves? So you guys have had a chance to see these. I sent them out to you electronically. The board one has been formatted a little bit, but nothing has been changed regarding the contents and so on. Are there any changes, suggested changes, or anything that you want to make to either the senior leadership team evaluation that they'll be doing or the board evaluation?
My only thought is that 57 questions is an awful lot.
Yeah.
And I wonder if it might be possible to pare that down a little bit.
Well, one of the nice things about it is at the end there's a place to sort of give general comments, right? And to give strengths, major strengths and weaknesses. So for the 57 anyway, it's really just about checking a box.
Slightly more than 4 questions a day.
That's 4 questions a day. So our hope anyway is that this will give us a broad picture, and it really just allows us to see trends. So we'll be looking at that, of course, but the place where I think the most effort will go into will be when you kind of summarize on what her major strengths are, areas for further development, and how she can address that. And I should mention that too to the members of the senior leadership team. I think what Julie's looking for is sort of specific suggestions about for improvement, as opposed to sort of general kind of thoughts like that. So if you have specific suggestions, be sure to let us know that, either at the in-person meeting we have or on the evaluation. Yeah, 57 is a lot, but I did cut out stuff regarding professional dress. So that was originally in here. So we did cut out some. Anyway, we did cut out some of those. Believe it or not, there were more. But
so like times 57.
Yeah, that's good. But so yeah, it's a lot. But I think since you don't have to give sort of short answers to each of those, hopefully that's.
And you need to give more than 2 weeks to complete it.
We can handle it. I mean, I think we can take it.
The 2 weeks.
Anyway.
This proof starts now, right?
Well, it starts when they send it out.
Oh, well, yeah.
So that'll be probably tomorrow. Yeah. So
Well, I
can fill yours out for you if you want.
This is good.
Oh well, thank you.
Defining what the various terms like good and excellent mean.
Yeah.
Is useful.
I mean, Carrie Youngblood has been very helpful. She provided really the template that we used, and I really just kind of tweaked it. So she's been very supportive in this process. I appreciate that. Thanks, Carrie.
Well, thank you to all 3 of you for putting this together, because that's, to me, is an enviable task, assembling something like this. So.
Well, I'd love to evaluate.
No, evaluating is great, but assembling the tool to do it sounds not fun. So thank you.
You're welcome. So I heard from Leanna. Any other suggestions for changing either of these evaluation?
Are we hoping to receive it back in hard copy or digital, or does it matter?
Well, I think we'll give it back to you in digital, but if you prefer a hard copy, probably better.
Like if somebody would
Oh, that?
Yeah. We've got check. Is the thought that
if you want to write on that and give it to me, that's fine.
Well, for the people you're emailing to, should they be printing it in?
That's up to them. But I imagine you'll probably want to email it back to me, so you can, if you write on it, just scan it.
Yeah.
And Mandy, I can help you with that. All right, thank you. I just committed her to doing something that she had. Anyway, so I don't, this isn't sort of an official vote thing. It's really just, does this sound good? Are there any issues or anything, or is this something that we all think we can use? Okay? Okay, so I will get that to Mandy to send out to all of you then tomorrow sometime, and I'll send the electronic version out to the members of the board tomorrow. Any last questions about the process? All right, thank you. All right, so we're going to recess now into executive session. Yes. Yes.
Could, for the planning calendar, could we now have it expanded to maybe at least the middle of 2019? Julie, are you hearing me there?
No, I'm
Sorry.
sorry.
Okay.
Well, the idea was just so we can plan ahead in
yeah, planning
2019.
calendar to maybe up till June or something of 2019.
Got it?
I also had
I'll get the flu.
housekeeping.
Sure. Yeah.
Like advocating for having the board packet on the overhead for people. I don't know, does everybody have the entire board packet? There's just one that sits there for, I think there's just one that sits over there for people to go through. Would that be difficult to, I mean,
Put it up.
because I like the Dropbox to display it up on the screen. Would that be useful to anyone to have the entire packet up there?
I don't know. I think right now most of us are working from either our tablets or from hard copy in front of us. Would there be a benefit to having it displayed each report as we sort of move forward?
Mostly, I don't know who all gets the entire packet. Is it everybody except like community members that come in and
We all get it.
So
It's also on our website.
well, maybe there is no need. Then I just thought that employees who come in and sit here, they were following along. But if this were over there, it's really fine.
I mean, I'm open to it. I don't think it would be that hard.
I should have another piece of paper in front of me, but the WISHA annual meeting is coming up. October 10th through 12th. It is at the Marriott Waterfront. It used to be about a day and a half longer than it is now. We do have rooms reserved for everyone, but I think, how much longer do we have to cancel?
Another week or two. I'm not going to be available to me. Is it at the Marriott or at the Edgewater?
It's at the Marriott.
Is this the same one that was at the Edgewater?
Yeah.
Is the conference at the Marriott or just the rooms and at the conference center across the street?
The conference center across the street.
Bell Harbor.
Yeah, Bell Harbor doesn't do that. They don't use Bell Harbor anymore. It's actually at the Marriott now.
Okay, that's
so you can still stay at the Edgewater because the Marriott.
Yeah, that's right. You absolutely can Edgewater, but
yes.
Right.
So I won't be able to go to that, but are there any board members who are interested and would like to?
I'm interested, but can't.
Okay. All right. Bob?
I can't on the 11th, but I don't know what's got 12.
Is this one of those things where they do the same thing both days?
No. This is an annual meeting.
Okay.
So there are some business meetings. AWB PhD has their annual meeting. I will be attending the rural committee meeting. They've freshened it up some, but it is more about keynote speakers and the business of WISHA.
That's when they froze us out of last year. It was so fun, that last session.
Yeah.
Bill, that's talking.
Was it
pending,
that
though.
in your hands were turning
I'm gonna pull out the gavel.
What's that?
All right. So yeah. So if you Bob, if you can make it, then obviously go ahead. But if you can't, it looks like the other four of us are available. Any other questions about the calendar? So Mandy, if you wouldn't mind putting together maybe for the first half of 2019, so we can just plan ahead, please. Any other questions about anything or comments before we move to executive session? Any questions? Okay, then hearing none, we will recess now into executive session to discuss personnel and real estate under RCW 42.30.110BG. How long do you think we need?
Half an hour.
Half an hour. So let's recess until 20 to 8. So that gives us 13-minute recess. And then we will reconvene into open session plan 10 after 8.
board meeting time? Is that
Well, we'll see. Yeah, I think that's a half an hour is always very considerate. All right, so we will recess into executive session. Open up in the public session 8 seconds.
Julia bragged about you today. How gentle you're.
You probably noticed it tonight.
It's just ever so slightly better if I touch it. Good.
I was trying to think of the
Last year I was hurt.
cardiologist.
Bye guys.